Live from Boston, my name is Emilio Madrigal, and today is Tuesday, September 2021, and I'm remotely joined by my good friend and colleague Rafat Manan. Today we continue our GYN OB pathology pathcast series, and this is the 16th lecture of that series. If you want to see all the other lectures, please feel free to visit our website, that's pathologycast.com, and you'll be able to see all the series and all the lectures for this GYN and OB pathology series on that site. Today, we welcome Dr. Andre Pinto. He's an associate professor of pathology at the University of Miami Miller School of Medicine, and the title of his talk is Endometrial Stromal Neoplasms. As always, please feel free to post your comments, questions in the Facebook and YouTube chat windows, and Rafat and I will be sure to pass those along to Dr. Pinto at the end of the lecture. So with that, I'll turn the microphone over to Dr. Pinto.
Good afternoon, or good morning, good evening, wherever you are. And thanks the Pathcast team for the invitation to present here today. My name is Andre Pinto. I practice gynecologic pathology at the University of Miami, and I'm happy to be speaking to you all today. The topic of my lecture today is going to be endometrial stromal neoplasms. And I'm going to be honest that when it was this suggested to me, I thought, I don't think I can make an hour worth of endometrial stromal tumors. But I guess I put a lot of pictures here, and I'm going to try to focus a lot on morphology, immunohistochemistry, and some of the differential diagnosis. And I hope that this will be helpful for you. So let's start with a case presentation, with a case example. So it's a 57-year-old female. She had a history of hysterectomy in an outside hospital for a quote-unquote uterine tumor. So we're not sure what was the pathology at that time. And she came to our institution presenting with multiple pelvic nodules, which was suspicious for recurrence of this tumor. And what I'm going to show you next is the biopsy of these pelvic masses or pelvic nodules. So this is a medium power view of this, I would say, spindle to ovoid tumor composed of cells with scant cytoplasm. You don't see a lot of pleomorphism, so the cells look, I would say, quite uniform throughout. There's some blood vessels evenly distributed. I don't see much mitosis. There's no necrosis, so there's no really much features of a high-grade tumor. However, other areas of the tumor did show, as you can see here, brisk mitotic activity, some enlarged nuclei, like some of the cells look more epithelioid, prominent nucleoli. And so it's kind of a biphasic or two different morphologies in that tumor. And when we did immunohistochemistry, what's interesting is that depending on the area that you stain or you apply your IHC, we had different results. So in the area that looks more spindle to ovoid and monomorphic throughout, this what I'm listing here is just the most relevant IHC. We've done more. So the tumor was keratin negative, Paxate negative. And of course, we always throw a Paxate as gynecologic pathologist. But in contrast was ER strongly and diffusely positive, CD10 positive, c-KIT negative, and the reason I'm showing c-KIT is I'll tell you in a bit. Desmin was mostly focal with some areas of patchy positivity, HCAL-desmin negative, and cyclin D1 negative. The areas that look more epithelioid, in contrast, also show keratin and Paxate negative, but hormone receptors such as ER was negative, CD10 negative, c-KIT positive, desmin, cal-desmin negative, and cyclin D1 strongly positive, approximately 80 to 90% of the cells. So with this index case, I think the questions that arise is, what's your diagnosis? And how common is to have these two distinct IHC profiles in the same tumor? So we don't see very often, right? Usually we see tumors that we stain different blocks, and they tend to have the same profile throughout. But how often does it happen in endometrial stromal tumors? And is there any other testing that we could do to just be definitive and confirm the diagnosis? So with this in mind, let's go a little bit of background of endometrial stromal neoplasm according to the WTO criteria. So this is the current classification. A lot has changed in the past decade or so for endometrial stromal tumors. But what I'm showing here is the most current classification, and we divide those tumors into endometrial stromal nodule, endometrial stromal sarcoma, or I'm going to be referring here and there as ESS or low-grade ESS, high-grade ESS, which this endometrial stromal sarcoma category, it's subdivided into low-grade and high-grade. And pretty much we're relying on the molecular abnormality that it's the signature of these tumors. So the low-grade, most commonly with the translocations involve the JASF1 gene. The high grade, which involves what I'm going to refer as YHA gene. And the third category involves B-core alterations. And it's alterations because those alterations could be fusions, like translocations, or it can be mutations, ITDs, or internal tendon duplications. And finally, a diagnosis of excluded, which it tends to be kind of a wastebasket. I mean, after you rule out all your endometrial stromal neoplasm with all the tests, if nothing stains, if nothing kind of predicts that this is a endometrial stromal sarcoma, then we classify them as undifferentiated endometrial sarcoma or undifferentiated uterine sarcoma, which is the preferred term. So with that in mind, as a whole, endometrial stromal neoplasm is the second most common uterine mesenchymal tumor. And 20 to 30% of the mesenchymal tumors are ESSs or ESTs. And as we know, if you practice gynecologic pathology, the most common by far is smooth muscle tumors, benign or malignant, and we quite often have to rule out that first before we entertain the diagnosis of endometrial stromal tumor. It can appear at any decades or any age range, but most commonly in the fourth and fifth decades. And these tumors have unique clinical pathologic features. For that, I mean that we're not really grading these tumors into low grade or high grade based on just the cytologic appearance. Actually, these are very distinct tumors in the sense that they have different IHC profiles, they have different molecular abnormalities, different prognosis. So that's why it's very important to classify correctly. And in terms of prognosis, if you really make the diagnosis of endometrial stromal nodule, that's a benign diagnosis. While low-grade endometrial stromal sarcoma tends to have an indolent course, while the high-grade endometrial stromal sarcoma could be, and it's usually more aggressive. And finally, that actually should be US or endometrial undifferentiated uterine sarcoma tends to have a very dismal prognosis. So let's talk about each one of them in a separate way. So endometrial stromal nodules or ESS, the way that these tumors morphologically present, the cells that are composed, these tumors consist of ovoid, very similar to the first picture I showed you, the ovoid to spindle cells that are very similar, if not identical, to your PE or proliferative endometrial type stroma. So as you can see here in the lower picture, if I put some glands scattered throughout, you probably wouldn't even call that a tumor. You think this is just PE type stroma. So that's how these cells are cytologically, that's their appearance. What's also characteristic of these tumors is to have this prominent small to medium-sized vessels that are consistently dispersed throughout the tumor. And one can only make the diagnosis of a endometrial stromal nodule after really making sure that that's no invasion, or which could be lymphovascular invasion or myometrial invasion, which we're going to discuss in a little bit, because these tumors are benign. And what classifies invasion? Like what's the original criteria for endometrial stromal nodules that we still apply nowadays? This came from Dr. Tavasoli and Norris back in the day when they allowed up to 3 projections of up to 3 millimeters each. Meaning if this tumor has 5 or 6, or if these projections are like, has a tongue, they have a tongue-like infiltration, or they exceed these, technically you could not call this endometrial stromal nodule. And another criteria is that no lymphovascular invasion is allowed. So either one excludes the diagnosis of endometrial stromal nodule. That's why sampling and making sure you have an excisional specimen is key in order to make this diagnosis. So when we say that, it's because if we do have infiltration into the adjacent myometrium, if we have lymphovascular invasion, then we kind of move away from the diagnosis of endometrial stromal nodule, and now we're talking about low-grade endometrial stromal sarcoma, low-grade ESS. And these tumors, cytologically, it's almost impossible, if not impossible, to distinguish from endometrial stromal nodules. However, like we discussed about the criteria, they commonly have a very infiltrative type of growth, which tends to be tongue-like, sometimes finger-like, or sometimes even blunt invasion into the adjacent myometrium. And lymphovascular invasion tends to be very easy to find in excisional specimens, which makes the diagnosis of low-grade endometrial stromal sarcoma. Here I put a little note that size and mitotic activity are irrelevant, meaning you could have an endometrial stromal nodule that will be 8 centimeters. That doesn't matter. It's still classified or be qualified as an ESN if you don't see invasion into the adjacent myometrium and or lymphovascular invasion. Here are good examples of this entity. And the first picture on the left upper side, you see this very characteristic tongue-like infiltration into the adjacent myometrium. And on the right side, the same exact morphology that we saw for endometrial stromal nodules, meaning these cells resemble PE or proliferative endometrial type stroma. And they commonly have, if not, like it's very characteristic, this small arterioles or the small little vessels consistently present into the throughout the tumor, as you can appreciate in this picture. And lymphovascular invasion tends to be very easy to identify, as you can see here as well. A few more pictures. So lymphovascular invasion, those nests of tumor cells within the capillaries of the myometrium. And this is a low power picture, which you can appreciate both of those features, a very primitive infiltration into the muscle and also many foci of lymphovascular invasion. Sometimes it's even difficult to decide, is this LVI, LVSI, or is this actually nests of invasive tumor? But I would say that probably these guys are all lymphovascular invasion. They're shaping around the vessels. All these guys here are infiltration into the myometrium. And here's a high power picture to appreciate or to show this nice round capillaries or small arterioles present throughout the tumor. Very characteristic of low-grade ESS or endometrial stromal nodules. One issue that we have, or actually there are two issues that I would like to bring it up, is that how to approach biopsy samples. And the first question, the first problem is how to make sure that you're looking at in a biopsy sample an endometrial stromal tumor versus, for example, a crushed polyp or just pieces of fragmented benign endometrium. So the key here is to see that once you see a lot of fragments, like a lot of really tissue composed almost always or only of stroma, endometrial stroma, that's a sign that it's probably not your benign endometrium that got fragmented. And quite often you see this expansive or sheet-like growth, which you tend not to see that in a normal endometrium. And one key to distinguish that from the polyps is that you're going to have those uniformly placed glands, benign glands from an endometrial polyp, which will point towards that diagnosis rather than an endometrial stromal tumor. The second issue is, okay, so I'm uncomfortable that actually this is actually an endometrial stromal nodule. Endometrial stromal tumor. How do I know if this is a nodule, like a benign, versus a low-grade endometrial stromal sarcoma? And I will say that in most cases, in endometrial biopsies or curettage, that diagnosis cannot be made, because if you recall from the criteria, we really need to see adjacent myometrium to qualify for invasion. And lymphovascular invasion is also key, which if you just have pieces of tumor, you may not see vessels adjacent, far away from the tumor. So in those cases, most authors would just recommend to be descriptive, write a note that if this is endometrial stroma neoplasm, see comment. In the comment, you say that you really cannot distinguish in small biopsy samples between a endometrial stroma nodule versus low-grade endometrial stromal sarcoma, and this will be best made at an excisional, meaning an hysterectomy specimen. Immunohistochemistry. CD10 and hormone, meaning estrogen and progesterone receptors, are the most classically used markers for endometrial stromal sarcoma or endometrial stromal neoplasms in general, and it's really diffuse and positive in the low-grade variants. You can also use other markers such as WT1, vimentin is just a non-specific mesenchymal markers. It's important to know that muscle markers such as desmin can be positive in endometrial stromal tumors. And that doesn't make into the diagnosis of a leiomyoma, leiomyosarcoma. You have to have in mind that quite often you have to use a panel to distinguish them both. And those muscle markers tend to be stronger in areas of smooth muscle differentiation. Same for sex cord markers. If you have areas with a low-grade endometrial stromal sarcoma with sex cord-like differentiation, which I'm going to show you a few pictures, then those areas will stand for example, carotene or inhibin. So that's something also to keep in mind. Another marker that has been described and validated in the literature is the IFI-TM1. I'm not very, we don't have that in our lab, and I don't have a lot of experience, but there's some good data out there showing that this is actually a reliable marker for endometrial stromal tumors, low grade, and sometimes even superior than CD10. So what are the variants that we need to be aware in order to make the diagnosis? There's smooth muscle differentiation, which creates this starburst appearance, sex cord-like differentiation, fibrous or fibromyxoid differentiation, a variant, ESS with glandular elements, and there's many others. There's skeletal muscle, there's pleomorph, there's many others, but these are the most common ones. And here's an example of a starburst or a low-grade endometrial stromal sarcoma with smooth muscle differentiation. So this nodule in the center that has a hyalinized core and there's more epithelioid cells. This is a smooth muscle differentiation. If you apply your desmin, caldesmin tends to be diffusely positive. And one is to be aware because sometimes they're very exuberant in a case, and to make sure to see to make the correct diagnosis. As you can see here in the periphery, we'll still have the convention or the spindle type low-grade ESS, which facilitates the correct diagnosis. Sex cord-like differentiation. So as you can see here throughout this picture, you have areas of more like a trabecular, vaguely organoid growth amongst these fibrous plaques, which also can be seen in endometrial stromal tumors. So this is something that if you use your inhibin, your carotene, or your SF1, those areas will stain. So which proves that that's some sex cord-like differentiation. And I guess the differential diagnosis here would be, for example, a uterosclerosis or uterine tumor resembling ovarian sex cord tumor, which by default, those tumors cannot have a ESS component. So once you have a combination of ESS plus these areas, that make into a sex cord-like differentiation of endometrial stromal tumors. The fibromyxoid, the fibrous variant, it's not more than just like a more fibrotic or more hyalinized background of the areas of the tumor, which gives a more eosinophilic and fibrous looking throughout this neoplasm. And finally, sometimes they see glandular elements in the endometrial stromal tumors, which can be challenging because one can, wonder, could this be adenomyosis? Could this be endometriosis? This is actually a case that I had, and in the ovary, which was metastatic from the uterus, had a lot of glandular elements. And at first glance, when you just look at it, you say just exuberant adenomyosis or endometriosis, depending on where it is. But I guess the key for the right diagnosis is to make sure that you do have areas of conventional low-grade ESS, and then putting everything together and putting the overall findings will be consistent with just glandular elements in an endometrial stromal sarcoma. So this is the ideal scenario of an immunohistochemical panel for these tumors, CD10 being the most commonly used, diffusely positive. I didn't show hormone receptors, ERPR, because this is to make an analogy to smooth muscle tumors, which it will be positive as well. Desmond and caldesmond ideally will be negative, but quite often we see tumors with or without smooth muscle differentiation that do have focal, sometimes even diffuse staining for desmond. So be aware of that. Do not use desmond alone. Do not use CD10 alone, because that also, CD10 can also stain smooth muscle. So put together morphology, put together a panel including caldesmond, CD10, ESS, if your differential diagnosis is with a highly cellular or a cellular leiomyoma, which is what I'm showing you right here. So this, if you just have a high power image, you start wondering, could this be a endometrial stromal neoplasm, or could this be a cellular or highly cellular leiomyoma? And the features that I tend to use to make the distinction other than IHC or immunohistochemistry is that in leiomyomas or smooth muscle tumors in general, you tend to have thick-walled blood vessels. And we just reviewed that in the endometrial stromal tumors, those vessels are small, they're delicate, and they're evenly distributed in the tumor. Another clue for the diagnosis of a smooth muscle tumor, meaning cellular myoma, is that at the periphery of the tumor, adjacent to the normal myometrium, we see the blending rather than infiltration. Cleft-like spaces are also commonly present in smooth muscle tumors, and you don't really see that very often in endometrial stromal neoplasm. And IHC, desmond, and H-caldesmond can differentiate. H-caldesmond tends to be slightly better to differentiate those two. So here's an example of a smooth muscle tumor where the vessels are larger. Some of them are staghorn, and you see clefts. And at the periphery of the tumor, you see the blending, like I was mentioning. So these tumor cells, smooth muscle tumors of this leiomyoma, actually merge into the adjacent myometrium, and it's also a good sign that this is a smooth muscle tumor rather than the infiltration or the tongue-like projections that we see with endometrial stromal sarcomas. One concept that I just wanted to bring up quickly is that these endometrial stromal tumors with limited infiltration. So what is that? So we learned that endometrial stromal nodules, you're not allowed to have more than 3 projections of 3 millimeters. However, what do we do in cases that, and the original definition is that they have a marginal irregularity exceeding that allowable for diagnosis of endometrial stromal nodule, but you don't really see the widespread myometrium invasion, which is commonly present in endometrial stromal sarcomas. So it was created back in 2002, this terminology of endometrial stromal tumors with limited infiltration. And here's a good example of it. So I wanted you to take your attention to this picture here, that most of the tumor is well circumscribed. So you say this is an endometrial stromal nodule, but then you have a projection that will be maybe 4 or 5 millimeters, which exceeds the allowable, here highlighted by CD10, and you can also see that in in low power magnification. So what to do with these tumors, how to classify. So for many years, we call them endometrial stromal tumors with limited infiltration, because most of the series that came out for many years show that these tumors actually behave pretty much like an endometrial stromal nodule. They don't really metastasize it, they don't recur. However, most recent data have shown, especially this work here from Dr. McLugage and Dr. Moore, that some of these tumors can, even if they just would qualify an endometrial stromal tumor with limited infiltration, they had cases, and here I listed a few case reports, including this case series, that they would present with distant metastasis. So just to summarize, if you see a tumor that has very limited infiltration, but it's slightly above what's allowed for endometrial stromal nodule, probably the best term or the best classification of those will be endometrial stromal, low-grade endometrial stromal sarcoma with limited infiltration, given that some of these tumors do have malignant potential. So molecular genetics, so these tumors are molecular classified or qualified by the presence of translocation commonly involving the JAS-F1 gene. And it could be the most common part in CIS12, but others such as PHF1 and many other genes partners can be fused with JAS-F1. Here's an example of a break-apart probe where you see the translocation. And most of the time, you don't really necessarily need a molecular confirmation, molecular diagnosis if it's classic morphology, classic immunochemistry, but sometimes it can be helpful when the diagnosis is difficult to make. All right, so that's everything we had for the low-grade endometrial stromal sarcomas and endometrial stroma nodi. So this is the endometrial stromal sarcoma, the high-grade groups. It's something that has evolved a lot in the past, I would say 5 years. A lot of the new gene fusion have been described, the classification has changed. And just to remind you that now we use high-grade ESS with the YHA fusion or translocation, and the ones with B core alterations. Those are the two current WHO groups that we're going to talk about. So what are the key features to make the diagnosis of a high-grade endometrial stromal sarcoma with a YHA translocation? So these tumors do show a permeative invasion, just like what we see in low-grade ESS. However, what's very characteristic of these tumors is this biphasic appearance. So we do have areas that look low-grade ESS, as you can see here. So the tongue light projection, the cells look, even though it's a low-power picture, but very uniform. And I wouldn't be able to call this high-grade if I only had those two areas. But in contrast, you have different foci with cells exhibiting high-grade cytology, more round, more epithelioid, and these cells tend to have necrosis, high mitotic activity, which tends not to be present in low-grade foci. We know that necrosis and mitotic activity is no longer a criteria to call low-grade versus high-grade. We used to be called in many, many years ago in the old classification, but it's something that we tend to see much more in the high-grade component. So here's a few examples of this epithelioid round component, which would qualify this tumor as a high-grade ESS. But again, some areas do still retain the low-grade phenotype. So when the first studies or describing this entity came out, I would say about a decade ago, interesting that cyclin D1, as you can see here, the genes that are upregulated on this family of tumors, one of them is CCND1, which is the gene that encodes cyclin D1. So the authors actually used that as a diagnostic tool. So can we use cyclin D1 to make the diagnosis, to help in the diagnosis of high-grade endometrial stromal sarcoma if we don't have access to molecular tools? And the answer is most likely yes, because as you can see in the rest of the presentation, a lot of these high-grade endometrial stromal sarcomas from different families, the different genes, overexpress cyclin D1. So here's an example, that part B here, the picture B, diffuse expression. We tend to like to be more than 70 to 80%. So patchy 30, 40% does not classify as overexpressed. So we really want to see diffuse expression of cyclin D1. And these high-grade components, high-grade foci, are most often negative for CD10, ER, PR, like hormone receptors and CD10. So that pretty much changes the idea that we had many years ago that if it's endometrial stromal sarcoma, it have to express CD10 and hormone receptors. And the answer is absolutely not, right? Because we know that the high-grade ESS, the high-grade components, are commonly often negative for those markers. One thing to be aware of, that these tumors can express KIT or CD117, but if you're looking at an abdomen in a recurrence, make sure that you throw also your DOG1 to exclude a gastrointestinal stromal tumor. So that was everything I had for the family of the YHA high-grade ESS. Most recently, B-core became one of the newly described variants of high-grade ESS. And there are two types of endometrial stromal sarcoma with B-core alterations, which all qualify as high-grade. First one is gene fusions, and the second one is internal tendon duplication, or ITDs, I was going to refer here. But morphologically, they are very similar. They tend to show a myxoid stroma in many cases. The cells can be spindle or epithelioid, but how can you distinguish that from a high-grade ESS, the one that we just saw with a Y-hay fusion? These ones with B-core are not associated with a low-grade component. So there's no biphasic morphology here. Everything looks very similar throughout, and quite often with these features that I just mentioned, which is the myxoid stroma, as you can appreciate here. They still have the classic morphology, the classic features of permeative infiltration into the myometrium, quite often lymphovascular invasion, but they tend to be very myxoid quite often. And other things that we tend to see with these tumors is the presence of HPC-like or hemangioparasitoma-like vessels, which can create a little bit of confusion if you only have areas that are hypocell like that. You start wondering, could this be a smooth muscle tumor? Could this be a solitary fibrous tumor? But the good thing is that you start to appreciate other features that are common from endometrial stromal sarcoma, such as the hyaline plaques, lymphovascular invasion, and the myxoid stroma. So here's another example showing the myxoid appearance. Cells in this picture look very spindle. They actually can be deceptively bland because they look relatively uniform throughout. Here's an example of it. So spindle, slightly hypocellular, and they don't really have a specific pattern of growth. They kind of grow in sheets, sometimes in fascicles. So we need really immunohistochemistry to make the diagnosis. And one thing to be aware of is that depending on the type of B-core alteration, the IHC can vary. So as you can see here, one thing that I wanted to point out before anything is that cyclin D1 still remains as a good marker. So regardless if we're like diagnosing high-grade endometrial stromal sarcoma with a Y-hay translocation versus the one with a B-core alteration, cyclin D1 can be considered as a relatively good marker for high-grade ESS as a whole. ERPR tends to be, as well as CD10, tends to be more commonly expressed in tumors that have the translocation involving B-core, while the ones with the ITD tend to be negative to focal. So just to be aware that ER and CD10 negative do not exclude, as we learned, a diagnosis of ESS. And IHC, it's available, a B-core immunohistochemistry is available. It's not very sensitive nor specific, but tends to be more reliable if we're talking about the B-core ITD or internal tendon duplication variant. While the ones with the rearrangement, it can be negative, it doesn't exclude at all. So, but one thing that before you make the diagnosis of endometrial stromal sarcoma with a B-core alteration, think about the uterine myxoid family of tumors, which can be very, very similar, and it can be a pitfall if you don't really understand the differential diagnosis. And these, I would say, the most similar tumors are the ones that you need to make I would say some immunostains or even sometimes molecular testing to make the differential diagnosis would be a myxoid leiomyosarcoma, which, since we know that smooth muscle tumors are way more common than any other mesenchymal tumor, is always have in the back of your head, am I dealing with a smooth muscle tumor? Because that will be your most common diagnosis. And the other one will be the high-grade ESS, especially the ones with B-core alteration. And another tumor that it's a lot of attention has been given the past few years is inflammatory microblastic tumor, or IMTs. They can look very similar. And here's an example of them. These are actually 3 real cases of these myxoid spindle cell tumors. And it will be very difficult to make the diagnosis without IHC. Yes, you can see the features that are more commonly seen, the smooth muscle tumors that are described, the vessels. But quite often, myxoid leiomyosarcomas actually have very infiltrative pattern of growth. So it's actually a characteristic feature of these tumors. So, which is very also similar to inflammatory microblastic tumors, high-grade ESS. So I don't, honestly, when I have a tumor that looks like that, I always do a panel of immunostains to make the diagnosis. And here's the correct diagnosis. So this is an inflammatory microblastic tumor. Yes, you want to see some of the inflammatory cells associated, but sometimes it's just very perceptibly like it's really not there. Myxoid leiomyosarcoma and B-core on the right. So once I face one of these tumors with myxoid stroma, I tend to do an immunochemistry panel, which includes muscle markers, which include ESS markers, and include an ALK. So if you have an ALK in your laboratory, IHC, that can be very helpful because it's a good marker for inflammatory microblastic tumors and tends to be consistently negative in those mimics. Another concept that I wanted to bring up is that, is there such thing as a low-grade endometrial stromal sarcoma progressing to high grade? Since these are tumors that are molecular defined, does it really happen? Meaning, like, if I had a diagnosis of a low-grade ESS back in the day, and now this tumor is behaving much more aggressively with the recurrence and looks morphologically distinct. So the answer is yes. There has been some cases of this progression from low-grade to high-grade. And in order to make the diagnosis, you really have to do the molecular testing to exclude that what you're dealing with, and you're trying to say that you call it high grade, is actually a tumor that does carry a JSF1 gene rearrangement. So this case series, which was published last year, had 12 cases, and they all, or I'd say the vast majority of them that were tested, had a translocation or fusion, which is characteristic of the low-grade tumors. However, they start showing some nuclear enlargement, prominent nucleoli, increased mitosis, so features that we tend to see with the high-grade family of tumors. Another interesting thing is that they start losing CD10ER, which it tends to be very often, if not all the time, expressed in the low-grade variants, and they start losing those. But cyclin D1, which is a high-grade marker, the good thing is that it was consistently negative. And there's limited data out there to say, like, the fact that histologically looks higher grade, could that predict a aggressive behavior? Because we know that tumors, sometimes they look horrendous under the microscope, and that doesn't really correlate with the biological behavior. And I would say leiomyosarcoma being one of them, we don't really have a standardized way of grading leiomyosarcomas, and you can have a tumor that is very indolent looking in the microscope, which can behave worse than one that has really pleomorphic findings in cytologic atypias. So in this case, it's limited, but possibly, yes, that could predict an aggressive behavior. And these are the pictures of the paper, which, as you can see here, will be cautious calling this low-grade endometrial stromal sarcoma, even in the presence of a JSF1 or PHF1, a PH1 translocation, because the tumor looks much more epithelioid, brisk mitotic activity, doesn't really look like your classic low-grade ESS. So be aware of that quote-unquote progression. Use your cyclin D1, which will be probably negative. And if you have access to molecular testing, that will still confirm that this tumor originally, or it still carries low-grade ESS signatures. And the last family of these tumors, which I'm not going to spend too much time on, it's just that so we are aware that this is an evolving group of tumors. And recently, this group published a B-core L1 endometrial stromal sarcomas, also high grade, and some of them were fusions, some of them were mutations, some of them were deletions, but they looked very similar to the B-core family of tumors, the high grade B-core family of tumors, including myxoid stromal changes, collagen plaque, and epithelioid areas. However, the gene that was involved was not BCOR, it was BCOR1. And this is just new data. There's not much more that we know about these tumors because the IHC was very limited. This group is a group from a referral lab, a molecular lab, so they didn't have much access to IHC or clinical data. But I wanted to show you that this is an evolving topic. I'm sure if I'm presenting this lecture in 2 or 3 years from now, we're going to have other family of tumors. And but as of now, the markers that we have in your hands still can diagnose the vast majority of sarcomas. And here's an example of the cases of that BCOR-L1 altered tumors, myxoid stroma. Some areas look more epithelioid, as you can see here in the middle. Some areas look more like spindle and fascicular. And if you have access to a broad genetic panel, such as next generation sequencing, I'm not sure if they did NGS or RNA sequencing in that study, but it's something that may eventually going to pick up those genes. So to summarize the pictures, this is the YHA translocated high-grade ESS, epithelioid areas, biphasic tumor, and the areas of each tumor or each component will stain differently, while the BCOR, quite often the spindle, myxoid, HPC-like vessels, but always use your immunohistochemical tools and, if possible, molecular diagnosis. And finally, the last entity, which is a diagnosis of exclusion, will be our undifferentiated uterine sarcoma. So by definition, these are high grade. So we don't really call high grade undifferentiated uterine sarcoma because it's just like the serous carcinoma of the endometrium. Those tumors are not to be graded. They're always high grade. And there's no resemblance to the PE or the proliferative phase of the endometrium. There's no line of differentiation after you do your immunostains or even by morphology. And histologically, these tumors are characterized by discohesive, quite often, sheets of cells with marked pleomorphism, tons of necrosis, destructive myometrial invasion. And the markers, like the ones that are I put some ESS markers here, because these tumors are, we don't really know if they're endometrial in origin or what line of orange they are. They can be like very focal here and there for some markers, but in general, they're negative for most of the markers that we use. And the definition that, in order to call that is there's no morphologic or immunophenotypic evidence of any cell differentiation. No skeletal, no smooth muscle, no fibroblast. So this is a diagnosis of an undifferentiated tumor. And same applies for the lineage markers. For example, if you do like your H. caldesma tends to be negative, your myogenin, your SMA may have a few areas here and there that are positive, but in general, they're negative for all the immunos, and they do not have any specific gene fusions or generic alteration. They can have a lot of chromosomal abnormalities, non-specific mutations, but no really fusions. Because if you catch a fusion, if you look at a tumor, you think, oh, this is going to be an undifferentiated sarcoma. You send for your molecular sequencing, and it comes back, for example, with a BCOR fusion or any type of like the ones that we saw today, then that completely rules out the diagnosis of UUS. And I can't, stress more, and I'm being repetitive. That's a diagnosis of exclusion after you rule out everything. And here's an example of it: marked pleomorphism. Cells look super ugly under the microscope. You can have lymphovascular invasion, and then you do a H. caldesma. You desmond tends to be negative. You do molecular studies; they come back non-specific. Therefore, you classify as undifferentiated uterine sarcoma, as you can see here. Pleomorphism, discohesive, very mitotically active tumor. So let's go back to our index case, the one that we started on, our patient. So if you remember from the beginning of the presentation, there was a tumor that had two different areas, one resembling proliferative type stroma, the second one looked more epithelioid, round with brisk mitotic activity. Immunohistochemistry was different. This tumor here was CD10 ER positive, cyclin D1 negative, while this component here in the same tumor was cyclin E1 positive, CD10 negative, ER negative. So what's your diagnosis? Yes, so this is the areas here, high grade, low grade. So this is a high-grade endometrial stromal sarcoma with Whitehead fusion, which belongs to the first category that we discussed on the high-grade endometrial stromal sarcomas. So how common is to have two distinct IHC profiles in the same tumor? It's actually very characteristic of this type of tumor. Since they have a biphasic appearance, the areas that are low grade tend to stain for low grade markers, and the areas that are high grade tend to stain for the high grade markers. And is there any other test that you can do to confirm the diagnosis? Again, if you really have access to molecular diagnosis, I would strongly recommend this to be a tool to be used on those tumors, because differently than the low-grade variants, the high-grade, they're not as clear-cut because there's so many variants and there are so many IHC properties in each one of them that I tend to send those for molecular testing. If you have a fish that would pick up the genes, a B core, a Whitehead, you can use that as your testing. But now I would say most individuals are using a more broad panel, such as next generation sequencing, which then you don't have to really pick the fusion that you're like, or select the probe that you're like looking for. Those modern next generation sequencing testing can identify fusions, mutations, and they'll be more helpful in this scenario. In terms of prognosis, so endometrial stromal nodules are not to be considered malignant, so they are benign, but low grade to high grade to undifferentiated, the prognosis gets worse as you move to the right. And most of the low grade endometrial stromal tumors or sarcomas are treated with anti-estrogenic therapy, because these tumors are ERPR strongly positive, and they feed on there's a good response if you use estrogen therapy. The high grade, because quite often they are hormone receptors negative, they tend to be treated with chemotherapy, and they have an intermediate clinical behavior or outcome. And as you move towards the undifferentiated, these tumors, unfortunately, very, very poor prognosis, show very poor prognosis, and chemotherapy also is not really effective, unfortunately. So in summary, just to kind of recapitulate all the entities we discussed today, endometrial stromal nodules, in order to make the diagnosis, you really have to examine the entire the surrounding areas. The excisional specimen will be preferred, because we're not allowed any myometrial infiltration, we're not allowed any lymphovascular invasion. And these are by definition benign. Low-grade endometrial stromal sarcomas, these cells are very similar to the ones in endometrial stromal nodule, meaning they're PE-type stroma, but the difference is that they show tongue-like or very primitive infiltration into the adjacent myometrium, and lymphovascular invasion is very easy to find. Hormone receptors and CD10, still classical good markers, and we tend to use them. And they're characterized by translocation or fusion involving the JASF1 or PHF1 genes. Then moving towards the high-grade category, we have the firstly described the Whitehead translocation, which is a tumor with biphasic appearance, biphasic tumor cell population. The areas that look low grade, the areas that look like high grade, and depending on the blocks or the foci you're staining, the immunohistochemical panel is going to be, or the results are going to be different. So it stains like low grade in the low grade areas, stains like high grade in the high grade areas, meaning ER CD10 negative. CD10 tend to be very helpful. And number 4, the ones with the B core alterations, it could be fusion, it could be internal tendon duplications. We do not have this biphasic appearance. We only have this uniform, vaguely myxoid tumor, which can express hormone receptors, can express CD10, depending on the type of genetic abnormality that is underlying. But cyclin E1, good thing is still reliably positive in most of them. And the genetic mechanism behind this is the translocations or ITDs involving B core gene. And finally, if you excluded all your tumors and you exclude the leiomyosarcoma, exclude rhabdomyosarcoma, PCOM, then you're dealing with an undifferentiated uterine sarcoma, which there's no characteristic generic abnormalities and there's no specific IHC markers. And just a few take-home points is that endometrial stromal sarcomas are a molecular defined group of tumors. So we're not just looking at how ugly this tumor looking. We're not grading just based on cytology. These are diagnostically distinct tumors which carry genetic abnormalities, and each one of them have different IHC properties. So in endometrial biopsy samples, as we know, it's sometimes really hard to make the diagnosis, and be mindful of the limitations. Write a note of your differential and suggest either rebiopsy or excisional specimen. CD10 and ERPR negativity does not by any means exclude the diagnosis of endometrial stromal sarcomas, because this is something that we've learned for the past decade, that these tumors can quite often be negative for those. So sometimes you have, some of my colleagues that do not do GYN pathology said, oh, I'm looking at this like tumor in the peritoneum or the pelvic area of a woman, and I thought about ESS, but it's ER negative, CD10 negative. So that's when you have to kind of remind them that this, depending on the category of tumor that you're describing or you're diagnosing, quite often that can be negative. And the final classification, it's putting together the morphology, the IHC, and if you have it available, genetic or molecular results. And to be continued, because I think that, like I mentioned, there's so much data coming with this molecular sequencing that we're now doing with these tumors. We're learning more from it. So I wouldn't be surprised if the next WHO in 5-6 years have a completely different classification from what we have now. With that, I'll thank you for your attention, and I'm happy to take any questions if you have.
Thank you so much, Dr. Pinto. Can you hear me?
Yes, I can hear you well.
Thanks for this very informative discussion on endometrial stromal neoplasms. I can see some questions online, and I think a couple of questions regarding biopsy diagnosis. So here are two questions which I found to be related. So the question is, one is about why endometrial stromal sarcoma diagnosis cannot be solely based on curettage. I think you have mentioned that. And the second question, which is kind of related, that in regard to the matter of establishing the correct diagnosis of endometrial stromal neoplasm on small biopsy, what's the most appropriate algorithm? Is it microscopic description? What do you suggest?
Right. So yeah, to answer the first question is that the reason we cannot sometimes make the diagnosis of malignancy in those biopsies is because we may not have, or quite often we don't have underlying myometrium to appreciate invasion, and also the same for like large caliber vessels to see if lymphovascular invasion is present. And the next question is like, why is it difficult to make? Is there an algorithm? I'd say like first we're going to make sure that it's this is not an endometrial patient that is taking hormone antagonists such as has a progesterone IUD or something that will make those glands very tiny. Be aware of that, because you really want to see the glands in between the stroma in order to call that benign. And sometimes crushed polyp, fragmented endometrial, inactive endometrial can be just composed of endometrial stromal cells, but that's why it's so challenging. You gotta sometimes write a note so that there's a lot of cells that raise the possibility. But if you don't see like an expansile or sheet-like growth, you don't see absent of glands that are evenly dispersed, I would be cautious to make that in small biopsies.
Right. Thank you again, Dr. Pinto. So there is some more question. Let me read them for you. So one is, I hope I will read the abbreviation correctly. UTROSCT is in the differential of ESS. How do we differentiate it?
Right. So yeah, that's UTR, like uterine tumor resembling sex cord ovarian tumor, TROSCT. That's a rare diagnosis. So first of all, like I would say, endometrial stromal sarcomas are much more common than UTROSCT. That's one thing to consider. And second is that endometrial stromal tumors can have sex score differentiation. But one thing that endometrial stromal tumors will have, if even in the presence of sex score differentiation, is that areas that are classic or conventional ESS in the background. So if you're looking at a case that has areas of sex score differentiation that makes you think about a utrust, you got to sample, you got to see other areas that will make it to a diagnosis of ESS, such as the presence of those cells, the PE-type stromal cells, lymphovascular invasion, the characteristic infiltration to the myometrium. So basically, I would just call the utrust once you excluded the presence of a low-grade ESS component in that tumor. And if you're still not sure, you can always send for molecular studies. Utrust should not have just F1 translocations. Actually, there's some recent data here also about specific genetic abnormalities in utrust, especially the malignant ones, which is different than the ones we see in ESS.
Right. Thank you. So there is another question. So this is about so weak and or focal expression of markers such as CD10, desmin, or cyclin D1. Does it exclude the diagnosis of undifferentiated sarcoma?
That's a great question, and I think it's. I've spoken with some of our. We have some very prominent soft tissue pathologists in our institution here, Dr. Rhonda Rosenberg, Dr. Montgomery, and I had the discussion, especially Dr. Rosenberg, in the past that I've had cases that are very, very focal. For example, a few cells here and there expressing smooth muscle actin, and then you do a caldesma negative. So when do you cross that line? What's their threshold to call this undifferentiated versus, for example, a high-grade ESS or a leiomyosarcoma? I would say it's a little bit arbitrary because the undifferentiated should not express any or very limited, but how much is the little? I would say if I see a case that has a few desmin here and there and SMA here and there and H. caldesma, even though if it's patchy, I would be more inclined to call that like a cytologically high-grade leiomyosarcoma because there is expression of some smooth muscle and muscle markers. But this is arbitrary. Ideally, they should be like very focal to negative. And the other thing that it's actually included in the criteria is that these tumors cannot harbor any genetic abnormality, so that is specific of other tumors. So if you're not sure, you send for NGS and it comes back with a translocation that is characteristic of endometrial stromal sarcomas and or things that we see sometimes in leiomyosarcomas such as MED12, TP53, and ATR, like things that are genetically common in leiomyosarcomas, then I would more incline to call those diagnoses. So just to summarize everything that I said is that ideally you should have no staining, but if you have a few cells here and there that you don't think it looks like a leiomyosarcoma, it doesn't carry any molecular abnormalities that will classify as a leiomyosarcoma or endometrial stromal sarcoma, then you're dealing with an undifferentiated tumor.
Right. So the next are two related questions I thought regarding molecular changes. So one question is, I hope I got it right. What is the cause for fusion of genetic alterations? That is one question. And the second question from another viewer is, are high-grade endometrial stromal or are HDESS YA rearranged expressing BCOR?
I'm sorry, Rifat, I missed a few words in the first and the second question. Would you mind repeating again?
Yeah, the first is, what's the cause for fusion of genetic alterations?
What's the cause for fusion? Well, that could be the determining genetic abnormalities on sarcomas, right? So when you have translocation or fusions that, which is like, it's just a genetic abnormality. Like same way you have mutations, some way you have amplification, sometimes we have translocations, and that would be the diagnostic and the driving pathogenic alteration for sarcomas and other tumors. So tumors have fusions, tumors have translocations, tumors have mutations. I'm not sure if that answers the question. The cause of it is just a genetic event.
Right. No, I'm also not sure exactly what was the question. The second question was, are AZESS YHA rearranged expressing B core?
The high-grade errors, yes. Oh, B core, I'm sorry, I'm thinking about cycling D1. I'm not entirely sure because most of the studies were done with the B core gene alteration, in which they're more commonly in the ones that are ITDs versus the ones that are translocated. But since I'm going to say about personal experience, I'm not sure what the literature shows. I've seen tumors that are not B core altered, and they do have some staining for the IHC. So I don't think it's a great marker, honestly. It's something that we use as a panel. So I wouldn't be surprised if the YHA ones can have some positivity, but I don't know the right data on that.
Right. So the next two questions are again somewhat related, I thought, and somewhat towards therapy. So first question is, what's the surgical therapy, and also in regard to certain translocation types? And the second one is, are there different types of high-grade uterine sarcomas with different genetic changes? They differ a lot in treatment modalities? Or we can give a final diagnosis of high-grade sarcoma?
That's a good question. I would say so. The first question is the treatment, if I understood correctly, is the surgical treatment, and I would say most of the tumors would be treated with a surgical intervention, and then after that, what follows that, I'm not sure if all of them will receive for low grade will receive anti-estrogenic therapy. The ones with high grade will probably require chemotherapy, but I'm not sure if that's depending on the stage or if that's just a general rule. So since I'm not an oncologist, I wouldn't be definitive on the answer of that. And the second question is if the translocation or the endometrial stromal sarcomas, I guess, will define the treatment. I would say yes and no. So if your differential will be a low grade versus high grade, then the answer is yes, because of the prognosis. The ones that are high grade, which carry this translocation that we talked about today, would be important to be diagnosed. So these tumors are treated more aggressively, while the low grade ones tend to be treated with anti-estrogenic therapy, like I just said. Now, the other question is if sarcomas in general therapy can be applied to high-grade ESS. That I would, again, since I'm not an oncologist, I would not be sure of the answer.
Right. There is another question. So, can we make a diagnosis of endometrial stromal neoplasm outside of uterus? For example, when it is associated with a foci of endometriosis?
Yes, the answer is yes. And one of the terms that it's commonly utilized is endometrioid stromal sarcoma. If you really don't have the uterine counterpart, meaning if this patient had a hysterectomy, it was benign, and now she has an ovary, if you diagnose endometrial stromal sarcoma, the correct term for that would be endometrioid stromal sarcoma, and that is correct, can be associated with endometriosis.
Right. So I think, Dr. Pinto, we have one last question from our online viewers. So what's the importance of accurate typing of these tumor category?
I would say, it all depends on which kind of tumors we're talking about. I would say if you're misdiagnosed a low grade for a high grade or vice versa, I think that's important because of prognostic implications and for treatment purposes. But if you don't have molecular studies or molecular tools in your lab, and you made the correct diagnosis of a high-grade ESS, but you're not sure if that's a B core or if there's a YA or if it's a translocation versus a ITD. I would say that may not be of much significance, because these tumors tend to have, some of them, like, of course they differ a little bit here and there in terms of prognosis, but I think they're all high-grade endometrial stromal sarcomas, meaning the treatment will be the same and the approach on these patients will be the same. So as long as you correctly classify, I would say, the endometrial stromal nodule as a nodule, the low grade as low grade, the high grade as high grade, and undifferentiated as undifferentiated, I would say you don't really necessarily need to subclassify the type of genetic abnormality if you don't have that tool in your academic institution, or if the patient cannot afford the testing. So as long as you get the umbrella diagnosis correct, I think that's all we need.
Thank you. I think these are the questions that I could find online from the viewers. And thank you again, Dr. Pinto, for this excellent talk and all the questions that you answered for our viewers. And you would be very happy to know, Dr. Pinto, that there are a few hundred viewers from so many different parts of the world. And I could keep track of some viewers who joined from as far as Bolivia, Algeria, Brazil, Abu Dhabi, Egypt, Libya, Mexico, Philippines, India, Greece, Argentina, and of course there were some from US as well. And thanks to our viewers for your continued support to Podcast. And if you like our lectures, please follow our YouTube channel. You can subscribe to the YouTube channel, that is Podcast, and also the Facebook page. You can follow and like it by the same name. And we have a website where all the lectures are organized by subspecialty, and the GYN pathology, all the previous lectures are available there, all the 16 lectures, including today. And in fact, today's lecture, you can also find a PDF of the talk on the website, which is already uploaded. And the website is pathologicast.com. And we also have a newsletter. You can subscribe to the newsletter so that you can stay updated with all the upcoming lectures. And our next lecture is on October 8th. So we will have a talk on CNS pathology. So there is the new WHO classification that has come up. So Dr. Fausto Rodriguez will talk on the 2021 WHO classification of CNS tumors, and he will focus on gliomas, how they are updated in the new classification. And again, the date is October 8th, and it would be at 12 p.m. Eastern time. So hope to see you then. And thank you again, Dr. Pinto, for this excellent talk and for your time. Thanks a lot.
Thank you, Rifat. Thanks for invitation, and thanks for the all the audience that is watching across the world. And congratulations on Pathcast on this excellent platform that it's made available to everyone.
Thank you again. Thanks a lot.